Hello InstaFam, how are you? It is Wednesday night and I'm coming to you yet again for a live Q&A. I hope you are all really well. I'm going to try really hard not to put my chin on my hand. It's a bad habit and I've been told that I've got to stop doing it. So I'm going to try really hard not to do it. Anyways, hope you guys are good. Coming to you from Dr. T headquarters once again in my favourite Wednesday night attire. I've decided that I've done most of my lives in this jumper, so I'm coming to you live in my favourite attire. Tonight we are all about Q&A, so if you do have any interesting questions to ask me, please don't hesitate to drop them into the chat. Just a little bit of a guideline around how we answer these questions. Please don't tell me your life story. Make them short and sharp because I'm going to try and make them short and as generic as I can for everybody, because we want everybody to benefit from the questions that you ask because they're all good ones. Someone has thrown me a DM, which I thought that I would pose here because I think it is a question that a lot of people ask about. And the first one, Roller B, why is it important to take progesterone before a transfer? You mean use progesterone before a transfer? I'm going to think, or are you asking why is it important to take a progesterone blood test? So just clarify that, but why is it important to use progesterone? If you are doing a natural cycle transfer, so let's say we're using your own natural cycle, you probably don't need to be taking extra progesterone if we are to assume that your corpus luteum produces enough of its own progesterone. Many of us practitioners, however, are a little bit nervous and anxious that perhaps you might not be getting enough progesterone, and that might be part of the reason why you're not conceiving. So we will often give you extra progesterone, micronized progesterone, usually in the form of a pessary because it's fairly patient friendly and it has been shown to be effective. But in truth, if you're doing a natural cycle transfer, then you probably can just rely on the progesterone produced from your own corpus luteum. If you are doing an artificial cycle though, where we give you estrogen and then we give you progesterone, of course you're going to have to take progesterone prior to a transfer because you need that to mature the lining to the appropriate environment and optimal window of implantation for your embryo. That's the long and the short of it. But just on that, a question that was thrown through to my DMs was also about progesterone. So I'm just going to continue on this theme for a moment. I know there's been a few more questions posted, but it has always been the bane of our existence, low progesterone levels during that optimal window of implantation. And there has been some really good research out of the EV lab in Spain. A big shout out to Dr. Elena Labata, who has headlined much of this research. But they have done a lot of retrospective reviews of large cohorts of patients, sort of 2, 3, 4, 5,000 patients. And what they actually have shown is that if on the day of transfer, the progesterone level is less than what would be about 20 to 25 picomole per litre of progesterone, so it all depends on the unit of measurement, then you're probably going to have lower pregnancy rates than if the progesterone levels are higher than that. So many of us sit with our progesterone levels above 35 where we're most comfortable. But really, if it's above 25 picomole per litre, you're probably in the right range. But somebody asked me on DM, is there a level where the progesterone level can potentially be too high? Is there too much progesterone around? And certainly there's some data back from 2015 which suggested there might actually be a place for not having too high a level of progesterone. Well, Elena Labata and her group from EV have actually looked at this more recently, and they've looked at a cutoff anywhere above what we would pitch at about 90 picomole per litre. And even at those higher levels, they did not see a significant reduction in pregnancy rates. They did see a trend to higher miscarriage rates, though this was not significant. But certainly ongoing pregnancy and live birth rates were not negatively affected by having mid-luteal progesterone levels on the day of transfer higher than 90 picomole per litre. So I think that's quite encouraging, because some of us do like to set our progesterones a little bit higher than that sort of 30 to 40 picomole per litre. Some people do like to sit a bit higher, and there is that concern, is there an upper limit at which we should be pulling it back? But it doesn't seem at this point like there's an obvious upper ceiling to how much progesterone. So that's kind of reassuring. Thanks for that question. That was a good one. Used correctly. Yes, definitely. So thanks, Roller B. Hopefully I answered that well for you. Britt Mariah, do you need to repeat a tubal patency procedure if you've had one, but it's been a couple of years? Look, if you haven't had any procedures that might have caused tubal blockage, or you don't have progressing endometriosis, or you haven't had some sort of surgery, then I think it's reasonable not to proceed to do another tubal patency test. I think it's also important to think about how that will impact your fertility journey. So if somebody was progressing to IUI treatment, for example, or ovulation induction treatment, I care more about their tubal patency than I would if they were, say, going to IVF. So if someone's going straight to IVF, I wouldn't even bother doing a tubal patency, even if it had been a few years ago. So that's a good question. Great, Roller B, glad you got it. Moving right along. Burke Megan. How could endometriosis be missed from laparoscopy 15 months ago? Don't know, my friend. Further failed for FETs, was only told age was a factor, now have endometriosis found. Again, I don't know your specific clinical scenario, so I don't want to speak out of school because I don't know the full context of your journey. But endometriosis is a progressive disorder, and it is quite possible that there was no endometriosis 4 years ago, and you might have clinically significant endometriosis now. We still are yet to really learn about the pathogenesis of endometriosis. There are cases where people have found endometriosis in cesarean scars, perhaps being transported there by surgical instruments. There have been case reports of endometriosis in the back of the eye, endometriosis in the lung. How did it get there? Why did it take so long to get there? Does it correlate with the extent of disease within the pelvis? And so on and so forth. So I don't necessarily think it was missed. I don't know. As I said, I don't know your clinical scenario. I don't know the experience of the surgeon. I don't know if they did good surveillance. I don't know if they did biopsies. I mean, there's all these questions that are unanswered in this space, but always understand that it is a progressive disorder, and unless it is suppressed by hormones, then there's a possibility that even after someone has resection, endometriosis can return. Roller B, do I recommend acupuncture before a transfer? I recommend it if you feel that it helps you. I am not convinced around the research on acupuncture prior to a transfer improving pregnancy rates. There have been randomized controlled trials in this space. Admittedly, the sham acupuncture that they used as the comparator might also have the same impact. So I think the jury's out on this. I do not think that it does any harm at all. And if it makes you feel good and if it helps to relax you, then go for it. I think it's of great value to the holistic care of a woman. Do I recommend any supplements? Roll a bit. You're rolling out the questions tonight, my friend. Do I recommend any supplements before transfer? Absolutely. Everybody needs to be on folic acid, 100%. If they're deficient in any other nutrients like vitamin D, they should probably be on that as well. But in truth, if you have a Mediterranean style diet, then that is probably going to provide you with all of the appropriate nutrients that you need to sustain a pregnancy. So that is probably my supplement kit. If a woman has a cold but no high temperature before a transfer, would you recommend transfer? Of course, absolutely. It is appropriate to, but please wear a mask, because like the rest of us do not want the cold, particularly if we're practitioners. You want to make sure that your practitioners are well and available to do your transfer. So don't share the love. Shona Brennan, can Ds and Cs increase your risk of ectopic pregnancies in the future? Any instrumentation that can increase scarring within the tubes may increase the chance of ectopic pregnancy. I don't think D&C itself is thought to increase the chances of ectopic pregnancies. Nothing has come to mind right now about the increased rate of ectopic pregnancies in association with a D&C, but anything that perhaps may cause complications may result in ectopic. So scarring, for example, may increase the risk of ectopic pregnancies, but the procedure itself, as long as it's uncomplicated, is unlikely to. Progesterone is given to make a woman ovulate before a transfer as well. No, it's not. No, in fact, progesterone will stop a woman from ovulating. That's why we use progesterone-primed cycles to stop the LH surge when, say, we're doing egg freezing, for example. So we can use it as an ovulation suppression. Progesterone is used to mature the lining of the womb to make it appropriate to optimise that window of implantation in the luteal phase. Monique Doherty, I had all my endometriosis removed via laparoscopy 2 years ago, and my second period after the surgery was straight back to the same pain and heaviness as it was prior to the surgery. I know, Monique, I've got to tell you that, and this is fairly standard practice, that surgeons will tell you, I may not fix your pain. I may be able to improve your endometriosis. I may be able to debulk your disease, but there is no absolute guarantee that I rid you of your pain and your period pain. Pain is a much more complex construct than that, and I could spend a whole night talking about pain, but I'm not going to. But if you have had laparoscopic surgery, the surgeon may or may not have told you that they may fix your pain. If they have not fixed your pain, then you must engage in a physiotherapist and or a pain specialist to help you recover from your disease process that has led to your pain syndrome. So no, it would not have grown back that fast. The other thing about endometriosis is that it is associated with infertility. I mean, the fact that you were unable to fall pregnant naturally and ended up doing IVF, it could be that you had some damage to the fallopian tubes as a result of your endometriosis and therefore couldn't conceive. You could still have had some microscopic disease left behind that impacts on the inflammation. And we also know that the lining of a woman with endometriosis is probably not normal, and that's why she has endometriosis. So we know that women with endo, even if it's treated surgically, will have much lower pregnancy rates, even with using IVF, compared to a woman that's never had endometriosis. It's a terrible disease. All right, last question for the night, because Winston, the crazy dog, is back and is tearing apart a doll as we speak. What happens if sperm DNA fragmentation has not dropped after 3 months? Would we have to do ICSI instead of IVF? Look, I think if you have looked at all of the possible pathologies associated with high DNA frag, it's not just about taking antioxidants, it's doing an ultrasound, looking for a varicocele, considering the health of the man, considering things like obesity, are they on any medications? There's lots of things that increase sperm DNA fragmentation that need to be addressed. So it's not just about taking an antioxidant. So if it's not dropped within 3 months, that is of some concern. And yes, you would probably need to consider doing ICSI instead of IVF. There would even potentially be a discussion about whether or not teaser sperm would be better than using ejaculated sperm. Okay, that's it for me today, guys. Oh my gosh, there's so many more questions that I don't have time for. Really quickly, can low vitamin D affect transfer? Yes, there's some evidence that vitamin D deficiency is associated with lower pregnancy rates. Bathina berry. I've been told it's a good sign that you even got pregnant after embryo transfer but ended in miscarriage, as opposed to not getting pregnant at all. Looking for silver linings. Just lean into that hope, my friend. Yes, it is good that you've had some implantation. Keep going. Right. I think that's it for me tonight. Thank you so much. There were some great questions. We had a very progesterone-oriented theme tonight. I hope that I have clarified some things around progesterone and progesterone levels and taking progesterone at the time of transfer and so on. Have a beautiful rest of your week. I did not jump on Friday, my apologies, to talk about menopause. Like I said, I would every Friday, but this Friday I'm going to, because I want to talk about something that is quite dear to my heart, and that is joint pain in association with menopause and how you can manage it. So if you know of anyone, tell them to get online on Friday. See you soon.